Hi, good afternoon, everyone. Bang on 12 o'clock. We're on time. All our tech worked, which is amazing. So thanks for joining us. For those that are joining us on LinkedIn, this recording is going to be recorded so that you have access to it afterwards. These Friday live sessions are all about us being proactive, positive, can-do, and evidence-based, actually getting stuff done. That's the real focus. We're not just here to moan about things. No doubt there'll be some issues that we talk about, but it's more about being positive and evidence-based solutions. That's really, really what we're about. In my book, Fit to Care, I really focus on we need more than just academic knowledge, more than business case knowledge. And that today's session is really, really going to highlight the importance of working with people that actually do the work. So that's what we'll glean today, the other layers of knowledge that together we can have wisdom to make much better decisions. That's what these Fridays are all about. So we'll just do a quick 60-second introduction with everyone, and then we'll get going. So my name's Anthony Lawton. I'm the founder of Fit to Care and Insight Genie. My big drive is public sector reform, and I've got too many years experience doing all sorts of things, but my big drive at the moment is AI, because that's where I see we can make absolutely ginormous progress. So that's me. So I'll hand over to Paul next.
Hi everyone, thanks for joining us this afternoon. So my name is Paul Rudd. I'm a health coach team lead in Wakefield for Trinity Health Group PCN and employed by Connexus, sort of our GP federation in Wakefield. My background's mainly in sports and exercise science with my master's and my undergrad in that realm, but recently got a certification in lifestyle medicine. And that's really what our coaching service is about. It's using these principles and psychological theories to just help people help themselves. So that's really my vested interest in this. And yeah, really looking forward to contributing with and hearing everyone else's presentations as well.
Fantastic. And I'll just remind everybody, you should have seen it, hence you've joined up, but this is all about does health coaching work? So that's going to be our real focus of today and the data behind all that. So over to Caroline next.
Thank you, Anthony. I'm Caroline Gibson. I am a GP and also a lifestyle medicine physician, but I'm also dual qualified. I'm a registered health coach and a qualified coaching supervisor. And I do some coaching work, but I also run a supervision program and I supervise NHS health coaches and a team of supervisors across the northeast of England, providing supervision and support to NHS health coaches.
Fantastic. And then over to Ollie.
Oh, well, thanks, Anthony. Yeah, lovely to have everybody here. I'm also a GP. I'm also a clinical director of a primary care network. Been doing that since it started 6 years ago. And I'm also founder of Peak Health Coaching, which is an organisation that provides accredited training, NHS accredited training for people in health coaching, care coordination, link workers. We trained a couple of thousand people last year. So I've got a real vested interest in making this happen. And I do that because I really passionately believe that helping people to self-manage really well is what's going to make the NHS sustainable.
Brilliant. And then Emma.
Oh, hello. I'm Emma Richardson. I'm a GP. I work in Devon. And I've got a really strong interest and a background in lifestyle medicine and preventative health. And I'm going to be talking about a project I did with the Health Coaching Association, putting sort of health coaching into a real life GP practice today.
Fantastic. So just before I hand over to Ollie to get us started, just reiterate how important it is for people on LinkedIn to put their comments into LinkedIn, because they will feed through to our dashboard so that we can bring you in and engage you in the process, and the whole panel can pick up on your comments and questions as we go. So with that in mind, I'll hand over to Ollie and we can get started.
Anthony, should we just hear from Adam as well? We might have missed Adam off on the intros.
Sorry, I did. I don't know why I missed Adam off. I thought I was top left. Sorry, Adam.
Don't worry. I've been having some connection problems there as well, so it was fine. I thought I'd just sort of skip by. But my name's Adam Davis, so I'm the Health and Wellbeing Services Lead at Pure Unity Health. My background is physiotherapy, so I'm a physio that specialised in chronic pain. I spent around 6 years as a first contact physiotherapist or first contact practitioner within primary care. And then have gone on to develop our health and wellbeing services. So that's mainly focused around health coaching and social prescribing. And our health coaching really started with focusing on chronic pain, and we're now developing that, but I'll go into that a little bit more when I talk to you. So yeah, great to be here, and I'll look forward to presenting our data.
Fantastic. And I guess everybody's comfortable with people leaving their questions and such like in the chat in LinkedIn, such that if you wanted to get in touch with Adam or Paul or whoever, we can pick that up in the comments afterwards.
Absolutely, Anthony. I think we welcome that, don't we? And the more you engage, the better, really, during this session and afterwards as well. So thanks, Anthony, for that. So I've got the role of just introducing this concept of sort of evidence-based and data-based information around health coaching. And we all know, don't we, as GPs, our colleagues are always going, well, what's the evidence? How does it work? Show me what shows me that this is worth giving my time and investment to. And there are definitely challenges with demonstrating that health coaching works. It's a new area, and people often want qualitative, sort of quantitative data, don't they? They want numbers. Does it save admissions? Does it reduce costs? Does it improve outcomes? And what's lovely about today is you will definitely hear some of those things, qualitative and quantitative, so stories as well as numbers. And I think that's going to be really interesting to sort of tune into. Having said that, I think when you're trying to assess the value of something new, you have to be kind to the stage of maturity. You know, for many of us, health coaching feels like it's a very established, regular thing we've been doing for years, and we've seen the benefits for years. But for many practices, for many PCNs, it's quite new. And actually, what you may need to measure is the kind of the early stages of setup. Do people understand what it is? Do they buy into the idea of self-management and building patient autonomy? And so I think, a little bit of sort of sympathy for those early stages. But then once it starts to be established, then we start to sort of think about, okay, well, are we training our staff well? Are we backing them up and looking after them with supervision? Do our patients and clinicians understand what we're offering? Do they know what's going on? And are the clinicians referring the right people, or are the self-referrals drawing the right people to it? So perhaps that's the sort of thing you start to look at as it's establishing. But then once it's fully matured, then actually what you want to be doing, isn't it, is looking at, how is the whole team working together and what sort of outcomes are they generating? We all want to see end outcomes, don't we? And my final point on this is that we want end outcomes that matter to people. There's no point in measuring things that kind of sound good, perhaps, a political flavour of the month, but actually they don't really matter to real lives. And what matters to patients, in my experience, it's very varied, but we have to ask them, we have to tune into what is it that actually matters most to you? What parts of the quality of your life are really important? But let's not forget what matters to clinicians as well. And as a clinical director of a PCN, I'm really minded that the quality of the work we do is very related to whether or not our staff feel they're able to do meaningful work. There's loads of data and evidence around that, that really matters. So perhaps we should be thinking about that as well. And of course, there is value to the system as well, isn't it? What is it? We do have to deliver things for the system. We've got limited funds. Everyone's very stretched and at risk of burnout at the moment. So what are we offering to the system with what we're doing? And I think you're going to hear bits and pieces of all those from our speakers today. So it's absolutely fantastic to have Adam, Paul and Caroline and Emma talking today. So I think I'll shut up and hand over. Is it Emma first, Anthony?
Yeah, I think so. If you can share your slides, I will let you open them.
Sure.
So please do, whilst we're waiting to get this go, just think about any questions or comments you've got. The more you add to it, the more value it is. It's all around, there's no wrong or right here. It's just about working out, how we're evolving together as a team. Thanks, Emma. Over to you.
All right, thank you very much. So I'm just going to take 10 minutes to present some work we did with the UKIHCA Health Coaching Association, where we put health coaching into practice in an NHS GP practice. So I know I've already introduced myself, but just give you a bit more detail. So I'm Dr. Emma Richardson. I trained at Imperial College and undertook a PhD in obesity research at Imperial. In fact, that was sort of in the lab that discovered the science behind the popular weight loss injection that's in the media so much at the moment. And I currently work as a GP partner and GP trainer in a GP practice in Devon. I'm taking part in the NHS Clinical Entrepreneur Programme as well. And in my spare time, I look after my 2 young children and enjoy exercise. And I'm currently also training to be a yoga teacher. It's quite busy at the moment. So just to look at sort of the problem. So we, as we all know, we're in the middle of the health crisis in the UK. Even though there's more information out there than ever about how to live a healthy lifestyle, and it's easier to access as well, the overall health of the nation is actually worse than it's ever been before. Obesity is on the rise, and more people are living with lifestyle-related conditions. All of this is happening while the NHS is already stretched to its limits. This sort of raises the question as to whether we're taking the right approach. Should the focus sort of switch more towards preventative rather than a reactive system? But right now, I think obesity and related health issues are costing the NHS around £6.5 billion annually. And if nothing changes, these costs are just going to keep going up. So when we developed the programme, we started by looking at the kinds of health transformations that often take place in gym settings, where people work towards a specific goal, combining fitness and diet, usually under the guidance of a personal trainer. Anecdotally, the results of these sort of programmes are very good, particularly in the short term. So we've taken that approach and built on it, adding a strong focus on education and long-term sustainable change. These kind of health transformation programs do tend to be expensive, they're quite labour intensive to run, and they're usually only available to people who can afford them, people with gym memberships and that sort of thing. And the reality is the people who would benefit the most from these sort of programs are often least likely to be able to access it. So we partner with the UK IHCA and with Antidote London. So they are a wellbeing provider with expertise in the design and delivery of lifestyle interventions in the commercial sector to deliver a 12-week health transformation programme. We recruited 40 participants who are all registered patients within the Colne Valley PCN, or Primary Care Network, which is a group of GP surgeries in mid-Devon. The selection of the criteria, so they all had a BMI of between 30 to 47, so they all had a BMI within the obese category. But apart from that, the inclusion criteria was very broad. We took the lead from the GPs. We emphasised that the patients sort of needed to be in the right stage in the change cycle, so they needed to be sort of ready to make a change. We took on patients who the GPs felt, or the patients felt, had sort of tried everything. Sometimes GPs felt that all the avenues had been explored, they didn't really know what to do next. We used a hybrid delivery model. So we had community events which had a sort of group consultation feel about them. So multiple patients could receive the same information at the same time. This is opposed to the sort of traditional GP consultation model, where in this case, having 40 patients, there would have had to be multiple 10-minute consultations over the 12 weeks, delivering the same information over and over again. And we paired this with a digital platform which offered support. So the support was in the form of, there was a group chat, which was sort of managed by the health coaches and prompted a bit by the health coaches. There was a message board where participants could sort of share experiences and recipes and gym classes and that sort of thing. It was also that we also used the technology for the patients to record their results. So they recorded sort of their weight and they recorded their food diaries, and the health coaches could access this. So we sort of streamlined things using technology. So the programme, just going through the different components of this 12-week programme. So there were 4 components. There was nutrition, and we emphasised whole foods and portion control, stayed away from sort of calorie counting and sins and that sort of thing. Then we also looked at movement. We talked about cardio exercise and resistance exercises. Then there was a community aspect that I just spoke about, so these 8 in-person community events on the digital platform. And then there was the support element, which was in the form of health coaching. And there was each participant received a 20-minute weekly health coaching session throughout the 12 weeks. And during these health coaching sessions, the coaches explored with the individuals their challenges, the individual challenges they were facing, the psychological barriers that were preventing the change, and how they sort of got to this point, and really kind of took apart the different psychological aspects. So at the end of the 12 weeks, there was a statistically significant weight loss with an average of 7 kilos between the 40 each for the 40 participants. And this is similar to the results that we see with the GLP-1 receptor agonists. So, you know, the fat loss injection like Wegovy, Mounjaro, Ozempic. As we know, though, these medications do have a number of unpleasant side effects. Our program, however, delivered the same results, but rather than side effects, it offered lots of benefits. So in addition to the reduction in body weight, there were statistically significant improvements in blood pressure, in waist circumference, hip circumference. There was also an improvement in muscular function. And this was demonstrated by an increase in grip strength, an increase in sit to stand and push-up ability. In support of this, we also use these body composition scales that are pictured. They were kindly loaned to us by SECA. And we showed that we use these to sort of measure the percentage of fat and muscle composition in the participants at the beginning and the end of the study. And we're able to show that approximately 6 kilos of that 7 kilos was fat loss. So they preserved their muscle. And the opposite is sometimes seen with the weight loss injection. It tends to be predominantly a combination of fat and muscle loss. So in addition to the sort of quantitative data, we also asked some qualitative questions. And we saw some impressive improvements in a range of aspects of well-being. So we particularly asked the participants about their sleep, their digestive health, energy levels, joint and muscular pain, mental health, social engagement. And of all the results the team found the most rewarding was that every single participant reported an increase in their happiness. They also reported a 49% increase in their overall health rating, and 100% of them would recommend the course to others. So one particular participant gave us consent to share her pictures and her story. So this is Amy. She's a 35-year-old woman who works in hospitality. When she joined the study, her weight was 116 kilos, putting her in the BMI range of 40 to 45 or class 3 obesity. She had a number of comorbidities to go along with this. She had depression, diabetes, high blood pressure, non-alcoholic fatty liver disease, chronic fatigue. She was on 10 medications. She tried every diet going, but despite this, she was bigger than she'd ever been. She admitted to being scared of eating food. She said that she would sort of starve herself throughout the day, and then she would go home tired and hungry, and she'd make sort of self-confessed poor food choices. She found exercise really, really difficult for lots of reasons, but she had this crippling sort of social anxiety where she found it really difficult to leave the house by herself. So this prevented her from even going on walks and that sort of thing. So yeah, she was in a really difficult place when she joined. She participated really, really well in the course. She was nervous at first, but really got involved in all aspects of it. And at the end of the 12 weeks, she'd lost 10 kilos. Her blood pressure was in the normal range. She was down to only one medication, and this medication was an antidepressant, and even that she'd reduced the dose. She also, probably the best part for me and for her, I think, was that she was no longer socially anxious. She had this new community of friends from the course. She became a health champion. She's really active on social media. She shared her story, and she reaches out to lots of people in a similar situation. She's also sort of offered, if we were to run anything similar, she'd love to be involved and share her story more widely as well. So just to close, just some closing thoughts. There are 6,000 people like Amy in the Colne Valley PCN that we were working within, and 15 million cases, people like this across the UK. These are all people with individual health challenges, with families, children who they can be passing on sort of lifestyle information to, people that are really being failed by the current health system. And as a working GP, I feel that the connection I had with these 40 patients is the best connection that I've ever had with any of my patients. And I'm one doctor delivering this level of care and connection to 40 patients across 8 community sessions, or eight hours really of my face-to-face time. We took the lessons that the fitness industry has been using for years and upscaled it, applied it to the people who really need it. The health coaching aspect did have a huge impact on the success of this course. And to come back to the first point I made, it's all very well giving people all the information in the world, literally at their fingertips. But how do you get them to actually make the change and do these well-researched interventions? And the answer is health coaching.
Wow. Brilliant. If you can stop sharing, Emma, we'll all come back on screen. That's amazing. That case study really brings it to life, doesn't it?
Thank you, Emma. Lovely presentation and bang on time.
Thank you.
Anthony, should we keep going to the presentations and then take sort of questions and discussion at the end? Is that?
I mean, it can be quite good just to have the quick question. If anybody from LinkedIn wants to ask a question at this
is that the best
stage,
thing?
then please do. It just breaks up, so it's not death by PowerPoint. So I think if there's any quick questions now for Emma, it will probably work really well to include them now from the panel. I've got loads to say, but I'll leave it to the professionals. So any of you guys just want to jump in there?
I mean, yeah, I'll definitely just go. But I mean, it's not really a question, I guess, but it's just brilliant to hear about using educating them about body composition. I think it's really important, isn't it, for patients when losing weight to think about the muscular mass, the metabolic health, and how that can improve all the biomarkers. So it's nice that they had that, and especially when it's met with that level of enthusiasm from the patients. And obviously yourself, Emma, you've got like a nice, obviously shows a really good outcome. So yeah, it's nice from that. Were there any challenges with that, I guess, is a question that I've got then, using the body composition scales?
So throughout the whole program, I really felt a real strong sort of angle on the education side of things and empowering the patients themselves to go forward at the end of the 12 weeks. So a lot of the sessions, I did give some sort of background about body composition and metabolic activity of different fat compared to muscle and that sort of things. They loved the scales. They really did find it really interesting. And yeah, I think they all sort of got on board as well. And I think sometimes when you're told to count calories, and there's so much information out there that not all calories are equal and that sort of thing. So they really valued the education aspect, and they went away and did more reading and then came back and educated the others. And it was really, really lovely to see.
I'm just going to fire some questions from LinkedIn at you now, Emma, if that's all right, just quickly.
Yeah, definitely.
So that first one, 20 minutes a week, is that enough? From
the health coaching point of view? Well, I was very lucky to have brilliant health coaches from the UK IHCA. And obviously, the more, we would have loved to have had more, but this is the NHS, there's a budget. And I actually think that check-in of 20 minutes every week was really, really valuable. Outside of the private setting, a lot of health coaching does have to be delivered in very short intervals, and so the health coaches were very skilled at delivering what they needed to do. And I suppose the fact that this was over 12 weeks, they could pick up on themes that could run throughout the 12 weeks. The nice thing as well was that they had this digital platform, so they could touch base with the health coaches, and it was not too taxing, I suppose, on the health coach's time, because just a little comment, and others, as they got to know each other, other participants started chiming in as well.
Brilliant. We're getting some really, really cool questions. Just a very quick one from Ollie. Ollie's having some sound difficulties, which is why we're just doing things by text here. But Ollie's point was, the comment around you choosing people who are ready to change. How did you manage that?
Yeah, so as I said, it was just a pilot study, and that's one thing that I would probably look at another time is the selection criteria and that sort of thing. But we very much, it's a huge PCN, so there are 50,000 patients, and we only had 40 places, and so we did sort of leave it up to the GPs, because they would have had, you know, at least a 10-minute consultation with the patients, and it did take a bit of time and commitment, and they had to be ready really to make the change. I mean, you know, you have to have the resource to make the change. You can't be, you know, in the middle of, you know, changing job and crisis in your life and decide to make a big change. So I think that was really important, and I left that to the sort of GPs discretion. I talked to all the GPs beforehand and left it to their discretion.
Yeah, brilliant. Another quick fire, 2 quick questions, and then we'll move on. So this one is, did the patient follow up? Did the patients follow a specific eating plan?
So again, we kind of really focused on education. The main points were whole food and portion control. So we stayed away from, you know, macronutrients and calorie control and that sort of thing. But a lot of it was, yeah, about education and really staying away from the processed food.
Yeah. Brilliant. And then the last question before we move on, are you planning to share this model?
Share the model. We'd love to get funding to get it out wider. Yes, I mean the results were incredible, and I think not just the kind of the data, it was the attitude from the participants as well. So yeah, I'd love to share it. Fantastic.
And I suppose you can update in the chat in LinkedIn, in the comments section in LinkedIn. So as things develop, you could maybe add comments in there, and people that have registered will get a pop-up message that things are happening, and we might end up doing more of these in the future as well. Fingers crossed. Okay, fabulous. So I think next up we've got Adam. Are you okay to share, Adam?
I am. Yeah. Can everyone hear me?
Yeah, we can.
Okay, perfect. Let me just share my screen. And can you see the screen?
Yeah, we can see.
Lovely. Okay, perfect. Good. So 10 minutes then. So I'm going to talk to you a little bit about our chronic pain support service and the data and outcomes that we've been getting. Just to quickly introduce myself again. So I'm Adam Davis. I'm the Health and Wellbeing Services Lead at Pure Unity Health. So yeah, physiotherapist by background. I've worked in primary care for the last 6 or so years, pretty much since the start of the FCP sort of role came into primary care. I've developed our primary care pain support service to try and help people with chronic pain, and really sort of focusing on helping primary care. So just a bit of an introduction of what I'm going to talk to you about. So brief overview of the chronic pain problem. And then a little bit about our journey sort of developing the service and why we got into it and why we started to use health coaching. I'll outline the service and the approach, and then get into the meat and bones of our outcomes, case studies, service evaluations, with some patient and stakeholder feedback, and just briefly touch on our next steps. So the chronic pain crisis, I mean, I think it's one of the really understated problems in the UK, with approximately 28 million people affected. And often those people that are affected with chronic pain are frequent attenders of the healthcare system. And we know that the top 10% of frequent attenders use approximately 40% of GP appointments. So people with chronic pain are really sort of frequent attenders, and we try to offload the GP practices by helping them to manage their pain better. It's also predicted to be the fastest growing long-term condition until 2040, with a massive sort of 32% projected rise, and that was the Health Foundation report. Waiting times into secondary care pain management services are often up to 2 years long as well. So people are often stuck in no man's land with limited resources in primary care and the community, and huge waiting times to get into secondary care specialist services, where obviously they don't really have that long-term support either. So it'll be a short term in that, or short time in the specialist service, and then essentially they're back in primary care. And around 70% of chronic pain is managed within primary care. We know that. So in terms of developing the primary care pain support service, so we have many years of experience working within primary care, so we kind of know the issues. We work in around 300 PCNs throughout the UK. An average of 50% of our FCP caseload was actually living with chronic pain, because we collect that data on every sort of patient consultation, and we look to try and find a solution for it. So we looked into the evidence, we looked at the recommendations following the ARMA reports, the versus arthritis reports, NICE guidance, all recommending that move away from medications and passive treatments towards a holistic approach based on personalised care and what matters to the individual. The evidence as well is really sort of turning towards combining pain science education with behaviour change strategies, and that's gaining a lot of traction in the literature. So we looked to integrate our first contact physiotherapists with health and wellbeing coaches to use those behaviour change strategies, and our initial outcomes were extremely positive and promising. So what we eventually did was move away from the physios having longer time and specific sort of chronic pain education sessions with the patients, and then having the health and wellbeing coaches as more of a supporting role. And we moved to a model where actually the health and wellbeing coaches were trained up as specialists in chronic pain. So they have that real sort of in-depth understanding of chronic pain. And they take people through the whole program. So it just integrates nicely with the FCP services within the PCNs. It can be booked directly in with the health and wellbeing coaches. So why health and wellbeing coaches? Obviously, it's a fully hours funded role. It's very cost effective, recommended by NHS England in that drive for supported self-management for chronic conditions. We know that it reduces GP appointments and offloads GP practice, and that personalised care approach is recommended in the NICE guidelines. There's more and more evidence coming out supporting health coaching, and in that last sort of 5 to 10 years, it's incredible the amount of papers out there. There's now literature reviews that are reviewing health coaching with MSK conditions as well, and that's becoming more and more well known that sort of health coaching behaviour change approach is really well recognised and gets great outcomes. So the patient journeys, we take referrals, as I said, from anyone within primary care. Patients can be booked directly in with that specialist health and wellbeing coach. They have an in-depth assessment where we really look at what matters to the patient, and they have then follow-up sessions, weekly 30-minute sessions. So again, that sort of touch point Emma mentioned about having a really regular 20-minute phone call being valuable. I absolutely agree with that. I think that regular touch point, that's one of the things that we get as great feedback from our patients. Just the model that we use there, it's not a strict criteria of working through modules. It's personalized to the person, but we have this general model where the first section is around sort of making sense of pain, and we've got our own resources, and we signpost to other resources that are out there. It then moves through to taking control of the problem, so sort of acceptance and moving forward, and then we start to look at the actual strategies. So what are those lifestyle changes that we can make that are going to have a real impact, and that's all the way from sort of power of breathing and mind-body techniques to getting moving with gradual progress, and how can we actually start to exercise and incorporate that into our lives. Just a quick sort of touch on the integration and community approach. There's a huge push for a community approach, absolutely right. So we try to bring people out into their communities, and we set up pain cafes wherever we can. And that's, again, getting amazing patient feedback. So that one-to-one coaching alongside the social support networks of a pain cafe is working brilliantly. So the impact of the service. One of the key things, our key outcome measure is pain self-efficacy. So we use the pain self-efficacy questionnaire, which is a really well-validated tool within chronic pain, and the average increase that we see across all our services. So this was an evaluation where we looked at all the data from our services from January 24 to January 25, and the average increase is 39% in pain self-efficacy, which when it's 9 to 14% as a significant change for the individual. You know, we're looking at massive changes here in their pain self-efficacy, which then has a huge knock-on effect on how much they use the GP practice and other healthcare practices. And it also has a huge impact on their managing with medication. So we see again around a 50% average increase in confidence in managing without their medications. So that sort of knock-on effect of deprescribing is fantastic. Just touching on the pain self-efficacy questionnaire and the areas, if you're not aware of it, the areas that it sort of covers. So it does cover the vast majority of sort of lifestyle habits, what you like to do, if you're able to do your household chores, how confident essentially you are at doing the various things that we have to do in our lives. So really powerful that I think we're getting such great changes within it. So the long-term impact, this was a pilot that we're working on in Doncaster, and we looked at an audit of a longer-term follow-up. So after 6 months, this is what we were looking at. So from initial appointment, those that had come into the long-term follow-up, the actual improvement there in the pain self-efficacy from start to 6 months was 87%. It was even more than our sort of general average. We also looked at the GP visits, so 6 months prior compared to 6 months following, 36% reduction in GP visits. This is ongoing at the moment, so that's with around 60 patients that we've looked at. And I'm really confident that we're going to continue getting those results. A couple of case studies just to draw your attention to. You can scan the QR code there if you wanted to have a little look, or have a look on our website. This was one where we looked at deprescribing. Another one here where we look at our coaching with Pain Cafe and just some feedback there. I'm running a little bit short on time, so I'll just the place-wide service evaluation in Bedford, where we worked across the whole of the city in various different PCNs, and we looked at thematic analysis of our patient feedback and our stakeholder feedback. So we did some thematic analysis, and these were the key themes. So emotional support and empathy, empowerment and coping strategies, therapeutic relationship and continuity, positive impact on mental health, practical advice and education. And this is one that I quite like, an unexpectedly positive experience, because you see that comment there. I thought, what's this going to achieve? But after the first conversation, I felt positive. I think that's the power of health coaching, and it's misunderstood, and it's really nice to see that people, once they engage with a health coach, how powerful that can be. The stakeholder feedback, so strong support for continuation of the service, positive impact on patients in clinical practice. We had a holistic educational empowering approach as a sort of key theme, and access to face-to-face appointments, because this was a purely remote one, which is not the same in all our services, but there's a couple of questions around how we could improve that particular pilot, which is exactly what we would do. I don't think we've got time for a case study, but if you wanted to go onto the website or talk them through, then we can definitely do that in a second, I hope. Potential cost saving as well. So looking at GP appointments saved does amount to, just with one whole time equivalent, if we're looking at the amount of GP appointments that we generally save, we are looking at huge cost savings here. This is a bit of an estimation, but then we've also got the cost savings from deprescribing, cost savings from increasing overall general health and increasing that patient activation, and reducing their modifiable risk factors. So I think the cost saving is actually a lot more than we could maybe put a number on. And I will pass over because I know I've just run over a little bit there. So thanks very much. If you've got any questions, feel free to reach out to myself, or have a look on the website for more info.
Fantastic. Thanks, Adam. If you can stop your share, we'll all come back on screen. Thanks, Tracy, for your question. I think Adam's done a pretty good job of the patient feedback side of things. I'll just pop this question up because it feels like a really strong one from Joe. If you just want to quick think about that one, Adam.
That's a really good question. I think health coaching and incorporating that into physiotherapy. Obviously, I'm a physiotherapist. I'm a trained health coach as well. I know firsthand how important those health coaching strategies and behavior change strategies are as a physiotherapist. Absolutely, I think we should be incorporating that into physiotherapy more, and that's something that I'm really passionate about, is educating our physiotherapy colleagues around health coaching. A lot will have gone and done motivational interviewing training potentially if they're going to work with chronic pain, but I think having that health coaching foundation should be in physiotherapy degrees, absolutely, and all physiotherapists that are postgrad should be getting that training. Linking the two together, I think, is really powerful as well. But I think what we've shown is that health coaches can do it themselves if they have that knowledge of chronic pain as well. You can get really good results with just having a health coach or a pain coach, as some people refer to them. But yeah, having physiotherapy input alongside that is, I think, even more powerful.
I'm sure you guys are all familiar. But I was shocked by those numbers. 28 million and 40% of GP appointments is astounding. Sorry.
Can I come in with a quickie, Anthony? Hopefully, is my sound working okay?
Yeah, we can hear you.
Yeah, brilliant. I mean, Adam, one thing Pure is particularly good at is getting data from patients. You have a really high feedback rate, don't you? What's your tricks to that? Because sometimes people feel a bit sort of reticent to ask patients lots of questions and use questionnaires. How do you feed that into your day-to-day working?
So, I mean, the pain self-efficacy questionnaire is a standard part of our assessment. So we track every single appointment. We track the pain self-efficacy questionnaire from initial assessment around midway, so after about 3 to 4 sessions, and at the end at discharge. So for us, I think using the pain self-efficacy questionnaire is a really nice one, because it allows people to reflect as well. So it's not just a classic questionnaire where we're looking at getting some numbers. It allows quite a lot of things to actually come out in that conversation when you ask them, how confident do you feel managing your everyday tasks, or how confident do you feel in socializing and meeting your goals. That then opens up a bit of reflection. So it actually ties hand in hand with that behavior change strategy that you're employing. So that works really nicely in terms of our patient feedback and
brilliant. So you make it part of it.
Yeah, exactly. But yeah, in terms of sort of patient feedback and getting testimonials, we have a questionnaire again that we send out to everyone, or as many as we can, and really sort of try and encourage them to fill it out, to sort of show other people what they've learned and how impactful the program can be. So yeah, we send that out to everybody, and we do get quite a good return on that.
Fantastic. One last quick one before we move on. I'm guessing we can answer this one quickly, give a feel for it.
So interested in training in pain management, how long does this take? I guess it depends on your background and where you're coming from. However, I mean, if you're a physiotherapist, for example, and you're looking to upskill, I mean, Ollie does a brilliant course in pain management. I think there's, upskilling is an evolving process, isn't it? You can get a baseline to what chronic pain management is and how to have those conversations. You're always going to develop. So it's how long is a piece of string, really, isn't it? But our health coaches, again, so they go through a program within their induction over the first 3 to 6 months of developing. But really sort of understanding that and sparking that curiosity and allowing the patients that we work with to build that curiosity, I think is, that can be learned fairly quickly.
Excellent. I'm conscious that we're going to be a little bit short on time, I think, but I think addressing these questions that come through are probably really, really valuable. So I'm okay with, if everybody else is, if we go a little bit over, so that you guys don't have to rush too much with your final section.
Yeah.
So shall we hand over? I think you're starting first. Who's going first out of you two? Are you sharing?
Yeah, we'll tag team. Basically, it's both our service evaluation. So,
yeah.
Caroline, am I sharing the screen?
Yes, please.
Let me share it. And if you guys just let me know if it's up and running in there. Can you guys see everything? I just obviously need to put it on full screen.
Yeah.
There we go. Looks good to me, Paul.
Fantastic. I'll move that out of the way.
Right.
Yeah, I mean, Caroline, did you want to start? Do I want to start?
Well, so we introduced ourselves earlier, and I work with Paul because I'm the lead supervisor for the area, and there was an opportunity to work with Paul's service, which brought us together. And the purpose of this session, very briefly, is just to outline our approach to coaching and then share the results of an evaluation of Paul's fabulous health coaching service in Wakefield. And we're going to look at both the outcomes for the patients, but also the impact on the healthcare system. So if we move on to the next slide, Paul. So I'm not going to talk about this too much because I think we all know, this audience will appreciate what health coaches are and how they came to be in the NHS. But just to highlight, it's that non-clinical, personalised care role to support individuals by working collaboratively to facilitate behaviour change, and really with the heart of this, and the heart of this is what matters to the patient. So practically, what does that look like in practice, Paul?
So, I mean, and also really a bit of a tangent, but it can look really different. I think it depends on the service you're in, your background as a coach, what your management and the system want you to deliver. But obviously, in context of this service evaluation, this is kind of what it looks like for us in Wakefield. So we just employ these evidence-based sort of psychological theories, a mixed bag of motivational interviewing, self-efficacy. I know that Adam's mentioned before about pain, but self-efficacy about health behaviours itself, and positive psychology. We're trying to move the coachees or patients to what could be possible, basically. It's something that I've drilled into all of the team. The idea of a health coach is to look at the individual as resourceful. They are the ones who can really, they're the masters of their own destiny, the captain of their own ship. So how do we pull that resourcefulness out of them? And as Caroline said, it's a very health coaching in the NHS, and for our service is a very non-directive, non-prescriptive, and it focuses more on them leading their own change and setting those personalized health goals just with what really matters to them, what's most important to them. There is a case study. I'm very, very conscious of time, so I'll whiz through it. This was a chap that was referred, also included in this evaluation, following his type 2 diabetes review. And he basically had a large increase in his HbA1c levels from 49 the previous year up to 72. And the diabetic nurse has referred him into the coaching service. As we all do with every patient that's referred, we give them a quick call, we triage, literally ask them what's important to you and try and marry up the options that we've got available. And this chap was really, really ready to engage. He wanted to take back control and wanted to, basically make changes himself with that support of the health coach. I always laugh. It says initial assessment, and I hate that. So in the first session with people, I always say this, even though it says initial assessment, it's not tell me about your health journey. It's really laid back. And from that first session, we're trying to obviously get the baseline measures from the scores that we've used and the questionnaires and metrics we've measured. But mainly it's a chance to build that rapport and focus on their why. And that's exactly what we did. So this chap was his goal was weight loss. And I kind of challenged that. I was like, that's not your goal. Why do you want to lose weight? And kept digging as a health coach, as you do. And it was really about improving his self-confidence, his self-worth. And I've not included it in the slides, but it was his relationship with his son. His son was playing rugby at an academy in Wakefield, basically. And he just felt ashamed that he felt embarrassed about the way that he looked, where his son was really athletic. So that was a really driving intrinsic motivator for the patient. And we will have these later on, so I will skip through these, but these are the pre-measures. Like I said, these will come back later on. So what was you trying to achieve, Caroline?
Yeah, so health coaching in the NHS, we aim to be really, really person-centred. One of the barriers that I found working with lots of different PCNs is that the management PCNs go, oh, well, but if you're going to be person-centred and decide, the person gets to choose how many sessions they have, then, oh dear, what's the impact of that going to be? So one of our evaluation aims is to describe how the coaching is used, like how many patients are being seen, how long is it taking, how many sessions do they have, but most importantly, what is the impact on the patients? What is the difference that it makes to people? But then what are the outcomes that we're getting, not just for the patients, but for the system? Is it cost effective? Is it reducing demand on other parts of the system? So how we did this, the main sort of quality outcome measure for patient impact is using the EQ5D5L scale, and we chose this because it is a internationally recognized, well validated tool, and because every patient is different, the actual outcomes and things that they bring to coaching is unique to the individual. So this is a very broad tool that looks at 5 areas of sort of overall well-being, looking at people's ability to self-care, their ability to be mobile, looking at their mood, their anxiety and depression, and their pain scale. And it also asks an overall question, that's the EQ-VAS, which is their rating of their overall well-being. And because it's a very generic tool, it's relevant to a lot of all patients. So for the EQ5D5L, we want to reduce people's problems, so a lower score is better. For EQ-VAS, we want overall well-being score to be higher. And so all patients will get that at the beginning and the end of their coaching intervention. So we also asked the health coaches to look at objective measures that were relevant to the patients that they were seeing. So because EQ5D is just what the patients are reporting, but we also looked at objective measures as well. So the next slide summarises that quite nicely about the process of health coaching and where the evaluation fits in. So as I say, all new referrals in to the service have these measures at the beginning and again at the end of their intervention. And the other thing that we have done is look at the GP appointments before and after, in 6 months before and 6 months after. So, Paul, do you want to talk about how patients engage with coaching? What sort of numbers do you see?
Yeah, for sure. So I think it just highlighted it in there, so I will skip over this. But we overall had quite a good level of engagement, and I always joke with one of my colleagues, one of my coaches in my team, that we hate a DNA. I'm sure if there's health coaches watches, there's nothing worse than getting 2 back-to-back DNAs. We want that engagement, and luckily across the spread of this evaluation, we had about, I think it was a 69% engagement. Let me see if there's another slide. They're all bits. So yeah, 69% of patients completed a health coaching intervention, leaving 31% of the patients that did not finish or lost to follow-up as well. What's really key about this as well is defining completed. That was basically when we agreed a number of sessions and we got there, or they said, I've actually got enough knowledge and skills, confidence to self-manage myself. And sort of touching upon what Caroline was saying earlier, we defined this and sort of contracted with the patients about the timescales. So there are, depending on where you are, some health coaching services have a number of sessions, maybe up to 6, talking about maybe specific topics. But for us guys and for my team, it's really not like that. It's very, very wholly person-centered. What do you want to talk about? How many sessions would you like? Why do you want those amount of sessions? And it's trying to just help them create their own ownership, I guess. And if we have a look at this kind of explains the spread of the number, on average, the number of sessions that we spent with the coachees across the service evaluation. So you can see on average, it was about 4 sessions where the most patients had 4 sessions in the evaluation. The amount of did not finishes was obviously higher after a single session or the first 2 sessions as well. So just to highlight that, I know that when I first started, there was a lot of apprehension from my managers. But if you leave it into the unknown, you might just be seeing them forever. But obviously this backs up that person-centered approach, was if you trust the individual and you use that health coaching skills, they actually can get to a series, you know, over 6 months, 4 sessions, and they're happy. They're happy to say, I'm completed, let's wrap it up. I'm ready to go. So it kind of supports this, where it's nice that we didn't have a number of set sessions as well. So yeah, what did we find from the service evaluation?
Yeah, so this is a summary of the patient-reported outcomes. So the first 5 are the EQ, 5D, 5L, patient-reported, how much problems were they experiencing with their mobility, with their self-care, with their usual activities, their pain and discomfort, and their anxiety and depression. And as you can see, that all of those scores went down, and patients reported reduced problems, which is what we want to see. And excitingly, their overall health score and their WHO-5 wellbeing improvement scores went up. And that all looks very pretty, but when in the next slide, when we look at the statistical significance of that, all of this is statistically significant. So this shows that patients feel better across the wide domains of well-being after their health coaching. So that is really, really positive to see. And as well as the patient-reported outcomes, we also looked at some objective data, some numbers. And Paul, do you want to have a quick look at those?
Yeah, of course. I mean, going back right to the beginning with Ollie mentioning about the importance of obviously qualitative and quantitative data to present. And I use the word language. I think if you're a health coach looking for data or looking for outcomes, presenting the objective or quantitative stuff, you kind of speak in the clinical language, aren't you? Weight reductions, blood pressure reductions. So it's a nice mixed bag, I think, is what we're trying to say. But for us, with the objective data, we haven't showed everything, but we can see here that we've got the weight and BMI reductions. I think the average weight loss was 5 kilograms, and it led to an average BMI reduction of, I believe it was 1.6. Doesn't seem a lot, but it was statistically significant. And also as well to note that our intervention isn't a weight loss program. It's a person program. It's a health coaching program. What do you want to do? So in the context of many patients that I'm sure, if you're a health coach watching, a patient's been referred to your service and they've said, I've been told I need to lose weight. And you might ask them, is that important to you? And they say, well, really, no. So it kind of goes to show that even though it wasn't a weight loss centered approach, we can still achieve, that statistical and clinical significant result as well. And just very briefly to mention on some other metrics as well, particularly the HbA1c. I think from the data, the average was 56. I think the mean average at baseline was 56 millimoles at the post-assessment, and then within that 3-month period after finishing with coaching, the mean average was 47 millimoles. So that's really nice because it takes them from that type 2 diabetic range into the pre-diabetic range. So a mean reduction of 9 millimoles for patients experiencing health coaching with us in our health coaching service. So it's really, really good. It's a nice result. But this is the stuff that I was really interested in. So Caroline, over to yourself.
Yeah, so this bit speaks to what the impact on the wider healthcare system, and does providing that health coaching intervention help people to be able to self-manage and therefore not need to go and see their primary care team as much. And we looked at both GP appointment usage and looking at appointments with the whole primary healthcare team, so from healthcare assistants, practice nurses, anybody, pharmacists, the whole healthcare team. And we looked at appointment demand for the 6 months before health coaching intervention and the 6 months after their health coaching intervention. And as you can see here, for both GP appointments and primary care appointments as a whole, there was a consistent 30% reduction for all of those appointments, which is just absolutely staggering. This, which I was absolutely delighted to see Adam's presentation earlier, which is their results are very consistent with this, that they're getting the same sort of scale of reduction in appointment demand, which is really exciting to see that being sort of replicated in different settings and different services. So I'm delighted to see that. So that's sort of numbers. How does that translate for real patients? Paul, tell us about your case study.
Yeah, so this chap, I mean, fair to say he was brilliant to work with. He was just really just absorbing everything from the sessions and was really present and just wanted to learn more about himself. So in total for this chap, we had 6 coaching sessions over 6 months. There's a couple of bullet points in there about his old behaviours. You know, he was really frequently snacking on lots of food, his quite high ultra processed food diet. He was drinking alcohol sort of every other night, basically, and he knew that he was over consuming in his units per week. He was very physically inactive. His job, he worked in a prison as a prison officer, but I think more sedentary, sat down a lot of the time. So yeah, he had a lot of things going on. But where we ended up, which was brilliant, after just 6 sessions, he sort of reported back how he's got these new behaviors. He really changed his diet, and what it was focused around was just including diversity of whole foods. And I think we spoke about it in maybe the second session, I think, where the diets in the past is a very reductionist mindset that a lot of diets or weight loss programs can have. I need to restrict this or remove that from my diet. And I love the phrase, how can you change that to an expansive mindset around food? What else can you add in? What other colors can you get in your diet? And that's kind of exactly the approach he's taken. So with that, increase the diversity of his foods, more plants, more fiber. He's now reduced his alcohol. What's really good, and the most important thing for him, is he signed up to the gym with his son. So he wasn't just going by himself. We talked about how peer support can be really important, and, you know, going to the gym is easy with someone else for many people. And he's going with his son now. So that's building back that positive relationship and what actually means most to him. And you can see in there that sort of feedback from our feedback forms that we sent out when coaches finish. And this is kind of what he's come back. And what I love most is the last sentence, because that was exactly what it was about. I wasn't leading the change. I wasn't telling him what to do. I just encouraged him to make his own plan. You know, he is resourceful. And then when you look at the bottom, the outcomes, he blew it out of the water, didn't he? I mean, 37.7 kilograms weight loss is incredible. And what was amazing was when he came back for his blood test, he had a huge reduction in his HbA1c back in a pre-diabetic range, meaning that we got him off his diabetes medications as well. And just to support what Caroline was saying about the reduction of primary care utilization, he also came back less as well. So yeah, health coaching, who knew? It seems to work, guys.
Mm-hmm.
And yeah, like I said, those are just the graphs, but you know, we can skim over those. And as well, that's good. If you just look at the EQ VAS, you know, it's gone up by 40 points. His perception of his health and well-being has gone up. That self-efficacy for him to take back control of his behaviors and his ability to do healthy things has improved, which is always going to be the most important thing. Caroline, I'm going to hand you over to this to talk a bit about.
And I'm going to ask you to kind of click through the next couple of slides really swiftly, because I'm aware that we've pushed for time. But so we've thought about, you know, it's brilliant seeing that inspiring case study of he's got such a significant health improvement for him as a person, but also reversing his diabetes, getting off his medications. But one of the things the system likes to see is, well, how does this all translate to cost effectiveness and funding of services? So one of the ways that we measure this is by sort of, you know, the NHS thinks of things in terms of quality adjusted life years and cost per quality adjusted life years gained. Now, so if we click through, so the idea is that a quality adjusted life year is 1 year spent in perfect health. And if you have a long-term condition, your quality of life will decrease and therefore you have less QALYs. So the aim of the game is to get as many QALYs as you can. And so if we click through, Paul, the idea is that if you develop a condition, you lose quality adjusted life years, and the idea of treatment or prevention is to gain QALYs. And as we move through, you know, we'll see that the problem is that with a specific treatment for like a specific condition that's a one-off treatment, that treatment quality gain is sort of static. Now, and we prevent a condition sort of deteriorating over time. The problem is with health coaching is that it's not that simple. It's not like we're just giving one set course of tablets and it's done. That we have a health coaching intervention, but people will change over time, and probably the effect is going to wear off. Habits, you slip back into bad habits. So what we see is this sort of deterioration in benefit. And if you click through the next couple of slides, Paul, so you'll see that the effect does wear off. We don't know how long the effect is going to be, so there's some estimation going on here. And as we click through, it talks through the how we've kind of worked out. And so I've kind of gone for a really positive best case scenario that we have health coaching and you'll get the benefits lasting for years and years. And so we've gone for 4 years. The best evidence I can find in the literature is that of intervention of health coaching effect lasting sort of 5 to 8 years. So we've gone 4 as a bit of a conservative estimate, and I went for sort of a year to 18 months as a more conservative worst case scenario. So moving through that, what we do then is we take the results that we had earlier, which if we think back to if we go on to the next slide, we take those patient reported outcomes that we have there, and then what we do is we combine all of those with a health economics program, and we create a combined utility score, which we can then use if we move on. We combine that to look at an overall score, which again beautifully is statistically significant improvement. And then from that utility score you can directly work out the costs and the associated healthcare costs of the quality adjusted life years that you have gained. So as I say, it's a range, and then obviously we've had some dropout. So when we've sort of done this work, we've worked out that we think that the cost per quali gained is somewhere in the range of £634 to just over £2,000. Now, really excitingly, that is very similar to the when we did this in a previous project. So we're getting consistent results when we work this out. And just compare this between what the rest of the NHS does and when it approves treatments. So, for example, any new therapy, any new treatment that the health service approves has to cost less than somewhere between £20,000 or £30,000, somewhere in that range, pounds per quali. Health coaching falls in the bracket of hundreds of pounds per quali. So it is massively cost effective compared to some of the other treatments that we are giving in the NHS, by a factor of about 100, which is incredibly cost effective compared to some of the other treatments that the NHS routinely offers. So in summary, I know I've just massively run through the statistics there. I'd be happy to pull them apart with anybody who wants to question me later. So I know I've just blinded you with the statistics. Paul, would you like to summarise all of that?
Yes, I'll be super snappy, super quick. So from our service evaluation, it showed that we did have a high level of engagement from patients, with the majority completing. Of that, we did have significant improvements seen across the patient reported outcome measures, and also some of the quantitative objective measures such as HbA1c, blood pressure, weight, and BMI as well. And lastly as well, we did see health coaching is now, we saw that it was associated with a significant reduction in patient demand for primary care and GP appointments.
Thank you.
Fantastic. Paul, if you can stop sharing, we'll all come back on. That's great. Wow, I'm really pleased that we decided that we'd run over a little bit, because watching those stats and looking at those results was really well worth the wait, I think. Really impressive, isn't it? There's not a lot more to say from my perspective. I'm a bit of a finance numbersy geek type person, so for me, it's absolutely brilliant. If there's anybody in the audience that wants to raise any specific questions, then please do shout now. But amazing stuff, really inspirational.
And whilst people are thinking, Anthony, I think What's really impressive is I talked about getting qualitative data that's comparable to other health interventions. So choosing the EQ5D5L was a stroke of genius, really, and that it allows direct comparison to other things. And so well done, Caroline and Paul. It's fantastic to show the value of health coaching alongside other things.
Yeah, it really is. My little summary would be from this whole session is, and it feels really close to human learning systems, if any of you are familiar with that work, but it's around about that person focused, isn't it? It's people focused, really listening to what people want at a human level makes just a huge difference. You can get things right first time if you do that, and the savings are colossal. Really good. I don't know if anybody wants to add any extra closing things. We're just getting good comments from the audience at the moment, which is good, but nothing to challenge anybody at this stage. So shall we just whiz around and just get everybody's closing views on it all? Shall we start with Adam?
Been a pleasure to be a part of this, and lovely to see the results from everyone else. Emma, Paul, and Caroline. I mean, it's great, and like you say, it's brilliant that all the results that we're getting are consistent across the board. So I think we just need more of that, and we're looking at publishing some of our data soon. I think the more people that we can get on board with this push towards preventative care. Obviously, it's huge coming down from the government, and hopefully the 10-year plan will give us some really good direction around that. And I just hope that it really does move forward in that way, rather than reverting to the mean and maybe sticking on that more passive medical approach that we know doesn't work. So yeah, fingers crossed for some good news over the next few months.
Yeah, brilliant. I'll go clockwise, Paul.
I think, just in summary, the name of these LinkedIn Lives, aren't they, are maintaining momentum for health coaching. And this, obviously, session has been really foundational for that in driving the impact and the data. And, a bit of a call to action for everyone still watching. I know we've ran over, but if you do have any outcomes and stuff, share it, blow the trumpet, get on the train, whatever we say, don't we, all the metaphors, but show it, preach it, because it works. And I think we're at the cusp now, I think, where health coaching can really start to be quite expansive across all sectors. So, yeah, just my call to action for everyone watching is keep doing the good work, keep fighting the good fight.
Definitely. Caroline?
Yeah, absolutely. Second Paul there with the keep sharing those outcomes. And what it's really lovely to see is that although our patients didn't have a specific outcome in mind, it was so person-centered. But despite that, we can still show positive health outcomes and impact. So it absolutely is possible. We just need to kind of keep going, doing more of this great work out there. Thank you.
Brilliant. Well, we'll keep sharing it. And then Emma, your view, and then I'll hand over to Ollie.
Yeah, I think it's really, really exciting that lifestyle medicine, preventive health has really been taken seriously. And it looks like everything's sort of moving in that direction a bit more with the political things that Adam was talking about as well. We're also looking to publish the data that we've presented. So yeah, it's just really exciting. I feel like health coaching is almost the sort of missing link to kind of bring the lifestyle and preventive health to make it become a reality for patients.
Fantastic. And then you've got the closing word. Hopefully we can hear you okay, Ollie.
Yeah, do tell me if it's not coming across well, but thanks very much to all our speakers. It can be hard work. Gathering data can feel like an extra thing to do, but we've heard today how you've beautifully included it in your regular practice and made it part of the value of health coaching, and it feel natural with your patients. And I think I'd encourage people to do that, and it helps us to keep making the case. This is a new area, health coaching. It's growing and maturing and evolving, and having the data to show its value is really important. So thank you so much to our speakers. You're inspirational at what you're doing. Thank you.
Fantastic. Really, really compelling. Thanks, everybody. Keep posted, because I'm sure we'll have similar ones. I think we've got another health coach session lined up for the last Friday in May as well. So hopefully see you at that one. Thank you.